Assalamu alaikum. This is me, Dr. Medrar. Today I will discuss a very important case which we encounter in our OPD setup, and most of the time this patient remain undiagnosed and mistreated. Before going to this case, it is important that any patient who present with a chief complaint of chronic cough always rule out a post-nasal drip. This patient, 45-year-old male, present to us with the chief complaint of chronic cough, and he used to constantly clear his throat and has a peeling of sore, scratchy peeling in the throat. It was present for the last 12 weeks, more than 12 weeks. He used to take a lot of medication for cough and occasional antibiotic for this, but his condition was not improving. So I took a detailed history in this case. On detailed inquiry, he was not suffering from any chronic illness like TB, because he does not have any history of weight loss or any night sweats. He does not have any history of previous shortness of breath or any wheezy chest or any smoking history, so I rule out COPD. I also ask about the gastroesophageal reflux disease, because acid may reflux to the throat and may irritate the throat and may cause chronic cough. So there was no history of that. The medication history, he used to take Cambivir and also occasional antibiotic. He was not on any ACE inhibitor and he was not taking aspirin, as ACE inhibitor can cause chronic cough, so you must take history of ACE inhibitor also and these medication. On examination, he was vitally stable, hand was clear, no finding present, no clubbing was present in the finger, and vitally stable. Anterior rhinoscopy shows that the mucous turbinate were swollen. He has rhinorrhea, mucus discharge, and also on pharyngeal examination, pharynx was erythematous and swollen and having secretion. Bilateral air was normal, SpO2 was normal. I checked oxygen on the pulse oximeter, it was normal, and bilateral chest was also having equal air entry and no wheezes or extra or any added sounds, and the rest of the examination was unremarkable. Based on my history and examination, I developed two differential diagnoses, as this patient have allergy also to dust and pollens, so maybe I presume it to be a case of cough variant asthma, but I rule out cough variant asthma because his pulmonary function test was normal, and also there was no previous history of any shortness of breath or wheezy chest, and bilateral chest was normal. So I came to the conclusion that this patient was having chronic sinusitis, which results in the post-nasal drip and resulting in this chronic cough. So I ordered CBC, complete blood count, X-ray chest and X-ray paranasal sinus view, and also pulmonary function test. On complete blood count, he was having mild leukocytosis with mild eosinophilia. Also on X-ray paranasal sinus view, the maxillary sinuses was having air fluid level, mucosal thickening was present and opacity was present. So, and also the X-ray chest was clear, there was no any finding on X-ray of the chest, and pulmonary function test was normal. So this was a case of post-nasal drip causing a chronic cough. This patient was well managed. I prescribe intranasal corticosteroid, like you can give beclomethasone or betamethasone, and anti-allergic medication was given. And remember, for acute symptoms you can give silometazoline or oxymetazoline, which is a nasal decongestant, and it can relieve symptoms acutely, but remember, don't give it for long duration, as it may result in rebound sinusitis. So I gave him for 3 to 5 days. Also I ordered to do regular nasal irrigation through normal saline. You can prepare normal saline in home it is available commercially. So you have to constantly wash your nose with normal saline so that the secretion and that allergens should go away with that washing. I also counsel him regarding allergy, like you should avoid dust and pollens, and also I counsel him to do steam inhalation as it gives asymptomatic relief. Ideally, this patient should have endoscopic directed mucosal biopsy or mucosal culture for bacteria and fungal infection, as in our setup it's low income. That's why I gave him 3 to 4 weeks of antibiotics. Ideally, antibiotics should be penicillin in combination with beta lactamase inhibitor like amoxicillin and clavulanic acid, and you can choose other antibiotic also, but this is the first line antibiotic. And as it was a case of chronic sinusitis, so I gave him for 3 to 4 weeks. So the key home message is always take a detailed history, detailed examination, so in order to reach the diagnosis. And also any patient present with a chronic cough, always rule out postnasal drip, because this is one of the treatable cause of chronic cough, and this patient was taking several medication for that, but his condition was not getting improved. So that was it. Inshallah, we will upload more video regarding clinical cases, emergencies and guidelines, various counseling for medico and also for public awareness. Inshallah, stay tuned.